Okay, so we are going to now take a look at the CMCS, the CPT. This is the introduction to the CPT. So what is CPT? It's the current procedural terminology, the coding rules, surgical package, Medicare surgical package, and definition. So we have intraoperative services with actual performance of the surgical procedures, and Medicare has two types of surgical packages. We have major surgical procedures greater than 10 days and minor surgical procedures 0 to 10 days. Major normally is 90-day global period. So you're looking at fracture care, you're looking at major surgery, your abdominal surgery when you get opened up. So again, 10 days from greater than 10 days, so 11 to 90 days for major surgery, and minor is 0 to 10. CPT is current procedural terminology, and it is the set of codes, descriptions, guidelines to accurately report services and procedures. Coding rules: surgical, therapeutic, laparoscopy, always included in the diagnostic laparoscopy, can never be charged separately. Surgical endoscopy always includes diagnostic endoscopy, can never be charged separately. Again, these are the things that are completed at the same time. Green surgical guidelines, that's at the beginning of the surgical section. And the CPT will identify what separate procedures are. And again, procedures throughout the surgical section will say separate procedure. These indicate it cannot be billed in addition to a total procedure that is integral, that it is an integral component, meaning that if it's completed at the same time through the same incision on the same anatomic area, then it's going to be integral to that procedure. However, if they open it up a different incision, if they do it at a different encounter, a different time, it would not be considered integral at that point. The example that we have is if a provider is operating on a digestive system and performs another procedure in the digestive system at the same time, both cannot be billed. But if the provider is operating on a different anatomic location, then it can be performed. So for example, if you're doing a digestive procedure, they're going in and they may be doing a colectomy, but at the same time they get in there and they notice that the appendix is inflamed, that it could rupture. If they don't, then they could remove that appendix as incidental to the other procedure, meaning that would be a separate anatomical site. You're on your colon, your intestine, and the other anatomic site is your appendix. Two separate locations. More than one procedure is performed, code and list the most expensive procedure first on the billing form. The reason for that is insurance companies pay 100% of the most expensive comprehensive surgical procedure or service, and then after that it's 50%. So multiple procedures, there are reductions to the amount you get paid. Surgical package, the 0 to 90 days, it includes in the CPT. Normally, the minor procedures aren't included in the global packaging. Examples, we have our OB is an antepartum, delivery, and postpartum care. We have fractures. They include the casting, the follow-up visit, surgical procedures, excisions of neoplasms. There's two types of surgical packages. You've got your CPT surgical package, which includes your local infiltration, metacarpal, metatarsal, digital blocks, or topical anesthetic. Your preoperative visit, your postoperative care, your written orders, evaluating patient in post-op anesthesia, And then complications during the post-op can be coded separately. Medicare surgical package is separate. The CMS definition of post-operative service differs from CPT, and basic difference is that the complications are included in the surgical package unless the condition requires returning to the operating room. So just for CPT, what that means is if we're going by CPT definitions, which is most carriers outside of Medicare and Medicaid, then if we have a complication and they return and they receive treatment for that complication, we can code that separate. However, Medicare requires if there is a complication, it's an extreme complication, then they're going to return to the operating room to address that. Then we can code it at that point. Otherwise, it is just considered part of the post-operative time. All additional medical and surgical services required of the practitioner to complications which do not require additional trips to the operating room is considered part of the surgical package for Medicare. Follow-up visits that are related to recovery from the surgery. Post-surgical pain management, Medicare. Supplies except for those identified as exclusions. Miscellaneous services such as dressing changes, local incision care, removal of cutaneous sutures, and staples, lines, wires, tubes, drains, cast, and splints are considered Medicare, included in surgical package for Medicare. Complications during post-op cannot be coded unless, again, they return for surgery. CPT content. It has 6 sections. So again, that's your anesthesia, your evaluation and management, surgery section, radiology, path and lab, and medicine sections. You have 2 categories. You have category 2, which is your performance measures, such as quality measures. Those are, for example, an emergency department visit. They are looking at care patients receive for chronic conditions such as diabetes and hypertension. If a patient has hypertension, they want to make sure that they are receiving blood pressure checks, they are receiving medication if they are elevated, or if they have not previously been diagnosed with hypertension, they are documenting that. So they are receiving the same type of care. But quality measures are selected based on the service location. Category 3 is for temporary codes or emerging technology. We don't always have a CPT code, and so a lot of times after they've been in the emergency technology, they will create a permanent CPT code. But until that occurs, we use the emerging technology. We have Appendix A through P. They are for modifiers that are exempt from our CPT codes that are exempt from certain modifiers. They are modifier usage. They are the vascular families. We have the place of service symbols, etc., that are listed throughout the CPT book. Place of service is going to tell us the location in which they receive these. So there is a complete list within your CPT. CPT assistance is going to give you further instructions as far as when you have 2 procedures, you're going to assign 1 comprehensive code. Or a patient comes in and they are treated a certain way, we are seeing certain complications, they give us further instructions and guidance on the appropriate and accurate reporting of CPT. We have the same thing for coding clinic by the AMA or the AHS for ICD-10. So we have the same situation. One is CPT assistance, gives us further instructions, especially when we see new codes in place. It will tell us further information, especially if we have integral components that we no longer assign 2 codes, we now assign 1. That would be an example. So our format, what we're looking at, guidelines. We have guidelines located in each section at the beginning, plus throughout each section, such as the surgery, we have them applicable to codes in selected areas. Imaging tip here, some codes require reporting of imaging in addition to the main procedure. Do not report separately if imaging is described in the CPT code. So again, you want to make sure that you're aware of the actual code description and you verify within the tabular, is imaging included in the code description or should we assign that separately? That is going to be one area that you are tested for the certification. Example of radiological procedures that are included in the code. One is 10,022, a fine needle aspiration with imaging guidance. It's included in that description, so therefore we would not assign or report an additional code for the imaging. Example that is not included and must be added to the procedure. What that's telling us is it's not in the description and we do have to report a separate code. So 20,206, there's a biopsy, muscle, and it was done percutaneous with a needle. The parenthetical note that's included there, it says if imaging guidance is performed, you're going to assign one of those codes. So you need to look it up to determine which one is appropriate. Coding tip. This is one that you need to be very aware of. Codes put you in the general area. They don't always put you in the definite area in the correct code. So you have to pay attention to the coding symbols, parenthetical notes, and guidelines to assign the appropriate code. Anything within your study guide that says tip or it brings your attention to it, you need to mark and be aware because there is a potential for either a true-false question or a question in general on that. CCI and MEU edits. You do have questions on this, but really and truly you do not have to go anywhere else to get the answer because they are specifically related to your study guide. But I wanted just to take this option and opportunity to let you look further at what the CCI and the MEU edits are based on what's on Medicare and where you can find them and locate them. On Blackboard, there are some instructions and there's some videos that are specific to the CCI edits, the MEU edit tips, but this is just to give you a refresher specific to this. So the CCI edits are specific for unbundling issues to make sure that you understand that in certain situations you can assign modifier 59, and that's on the codes that are specifically that say separate procedure in the CPT. So what you need to ask yourself is, can I build both of these procedures together and can I use a modifier to unbundle it? In the Excel spreadsheets, as we go over the ones that are coming up, it's going to specifically show you that. The MEU, medically unlikely edits, and so it should have been MUE instead of MEU. Excuse me. What it should have stated is the maximum number of units that are allowed by the same provider on the same day. So this tells you that we normally see these for drugs and for other tests and labs. So that's what we're looking at right now is what's on the screen is these are labs, these 86,000 codes. These are for labs. So how many times could one provider actually run labs and bill for them? So in the second column, what you're seeing is the maximum number of units. For 86,850, it says we can do that 3 times in one day by one provider, whereas 86,880 says that we could bill it 4 times per provider per day. 86,890, 891, 900, 901, you can only bill once per day per provider. So for that, when you're looking at your EOBs that we're going to look at later, there could be a maximum amount that's allowed. So once you surpass that, that's where you may get a note back that tells you that you cannot bill for those additional lab works. And it's because it surpasses the maximum allowed. If you go to the hyperlink on the CCI edits, the HTTPS CMS, it gets you directly to the correct section on the CMS website. You can find it. It's if you review the instructional videos that I have on there for the NCCI edits, the LCDs, it will also get you there as well. What you need to look at is when you are on this screen, you look at, are we looking at hospital? Are we looking at practitioner? The effective date. So as you can see, we have hospital, practitioner, hospital, practitioner. The difference between these is one is January 1, 2020. And if we go down to the next hospital, it's April 1, 2020. So depending on when are you billing, does your data service fall in the first quarter or the second quarter? So you want to utilize the information from the appropriate quarter for the visit that you're looking at. Then from that, this is procedure to procedure. This is going to tell us, can we bill this procedure with this secondary procedure? Then again, that's it. This is how many records. These are your codes. So the first set of codes, this 0001M through 80,050 is your first column. The second one is your 27,894 through G0471. So first column, second column. So your comprehensive code with your potential component code. So now what we have is we have an actual, just a small section of what your Excel spreadsheet looks like. These go on forever and ever. One good thing is you can actually do the find the code, so it will take you to that section. As you see, the comprehensive code is 11,402. Our component codes are 36,406, 43,752, 51,701, 51,702, 51,703. This is a lesion removal, and these are catheter placements. So although one really doesn't have anything to do with another, per CMS, there's a good chance that when someone is undergoing this based on where it's being removed, that they could be under anesthetic, which would mean that they would have a catheter placement. So in the grand scheme of things, it tells us that those are potentially bundled procedure. Not necessarily that there always are, but that's what it tells us. So not every procedure bumps up to another procedure. However, there are certain ones, EKGs, catheter placements, medications, that can bump up and cause denials or rejections based on that. So how you read this spreadsheet is this. It's normally at the top, but I went ahead because I wanted to make it more legible and readable other than putting just a complete spreadsheet on here. But if, again, you look at those other instructional videos, it gives you what we're looking at on the CMS website. So again, we have our comprehensive code. Column 1 is the code that we are going to bill. Column 2 is the additional code you want to bill with comprehensive column 1 code. So those are the two you want to bill. Can we bill them? We can bill them based on this column here. 1, 2, 3, 4, 5, 6th column. And this gives us a modifier that either tells us 0, it's not ever allowed, 1, it is allowed, or 9, it's not applicable, meaning we can't unbundle or code it together. So 0 and 9 means that we can't code them together. So up here, 1142 and 36406, there is a 1. So if we had both of these documented on this same chart during the same visit, we could assign both of them, but we would have to put modifier 59 on the second one, or the acceptable modifiers that Medicare has, which is the X modifiers. If we try to assign 11402 and 36592, column 6 has a 0, says we can't unbundle it. So it does not matter when it's performed, we can never unbundle those or report those together. So we could simply only report the 11402. And if we did assign the 36592, we would get that denial on that 36902. 592, excuse me. On this one, we can't really see it. It's 61,659, I believe is what that says. That's telling us it has a 9, so we can't unbundle it. We can't report 11402 with the 60,000 code. We would only simply report the 11,402. So that's what you need to know on your certification. What does the CCI edits tell us? It tells us, can we unbundle and can we report two codes together? Can we report a component code when it's documented appropriately, meaning it's a separate time, a separate encounter, a separate anatomical site, separate location? We can then report them together with the appropriate modifier. NCD and LCD. NCD is national coverage determination, meaning across the entire United States. LCD means local. So Arkansas would be different than Texas, would be different than Georgia. So we're looking at specific carrier information for our location. So national is just across the board. Medicare is going to code one way for all states. Then we can break down further CPT services, diagnostic tests locally, where in this particular area, this covers it. So again, NCD is National Coverage Determination. It's CMS standards on how things are paid and supports medical necessity, stating that when you go on here, that for this procedure, such as an EKG, we have to have a cardiovascular sign and symptom to support the reason for the treatment. It can't be a specific definitive diagnosis, because if we know that diagnosis, then why are we utilizing that diagnostic test to further clarify that? So we need dysrhythmia, we need shortness of breath, we need upper arm pain, chest pain, something of that nature to support that reason. LCD is local coverage determination, and its indication limitations of coverage for CPT and HCPCS. Again, that's going to give us medical necessity. What ICD-10 is supportive of the CPT and HCPCS. Modifiers, key tips here. This is just going to break down all the modifiers for CPT. So with modifiers, we have level 1, HCPCS, which is CPT, modifier numeric, and they're 22 through 99. Not all carriers recognize modifiers the same. So again, Medicare, this is where Medicare differs from CPT, meaning Medicare uses, instead of modifier 59, they want specifics. XE is a separate encounter. XS is a separate structure. XP is a different provider. And XU is distinct from the other procedure, from the comprehensive code. So we would use XE through XU instead of 59. Level 2 HCPCS modifiers are alpha and alphanumeric. They're A1 through VP, normally found in the HCPCS book, but we do have some listed in the CPT, such as your eyelids, your fingers, your toes, and TC for technical component. Tip here, not adding modifiers or inappropriately appending modifiers can negatively affect payment, reimbursement, and it is the coder's responsibility to append modifiers correctly. So that could be a true-false question. It could also just indicate that you are going to be looking at modifiers and understanding the definitions, the descriptions, and in what instance or examples would you append certain modifiers. To append or not to append. So that is the question. When do we append? When do we not append? We append when it justifies the clinical circumstances, when there's 2 physicians to see a patient on the same day, multiple procedures at the same visit, informational clarification, and they impact reimbursement. And again, we want to assign those modifiers that are payment specific first before informational. Because if it's going to impact the amount of reimbursement, we want to assign those first. You do not want to append modifiers if it's going to bypass an NCCI edit. That would be an example of when we had that modifier 0 or 9, and it tells us we can never bill those because you're getting that error back when you do the claim scrub and it's telling you that you can't bill that particular CPT. It's more than likely because you're assigning that modifier 59 inappropriately. Unbundling, that would be an example of unbundling, where we want to take that component and bill that separately from the comprehensive code. And code description specifies all needed information. Again, is the imaging included in that code description versus not? Okay, so what I did was I took the modifiers that you have. I have now indicated for that particular modifier, what instance would you append it, what it is, and then maybe an example of the appropriate and inappropriate usage. 22 is for increased procedural service. So it was significantly greater than what's normally expected. Acceptable reason for extended time is there could be some scar tissue, some excessive bleeding, so they had to go in and suture, or the scar tissue, the adhesions had to be removed, so there was extensive amount of time. What's not acceptable is they just simply said they had some difficulty with the procedure, or maybe a few extra minutes were spent on the procedure. That doesn't justify it. Where you're going to see it used is with anesthesia, surgery, radiology, path, medicine section, and the ambulatory surgery center is not going to use it. That's for that particular thing. Ambulatory surgery centers don't use all modifiers. They only use certain ones. So in this particular instance, if you work for an ambulatory surgery center in the future, that could be beneficial to have this. 23 is on anesthesia, so it's unusual anesthetic. Indicates general anesthesia was used for a procedure that normally is just local or general. So the example is the mentally handicapped patient that cannot have local anesthetic. 24 is on an evaluation and management. It's unrelated service by the same provider during the post-op period. Example, patient has post-op check and talks with the doctor about their diabetes at the same visit. So diabetes wouldn't be connected to the post-op. 25 is on an evaluation and management, and we can also use it in the ambulatory surgery center. Significant, separate, identifiable evaluation and management service by the same physician on the same day. Example, we had an office visit for hypothyroidism, and they also had a wart removal. 26, surgery, radiology, path, and medicine. It's a professional component typically used on radiology and cardiology procedures. So the radiologist read and interpreted the x-ray. We would append 26 to that radiology. 32 is used on everything but ambulatory surgery center. It is mandated services, so it's required by the lawyer, workers' compensation, legal reasons, and it's not for second opinions or requested by the family, patient, or another physician. So work comp insurance requests an opinion regarding second back surgery. Is there a reason to have it? 33 is our preventative services, and it's on evaluation and management and surgery. So screening and treatment for discovered conditions. For example, you have a screening colonoscopy completed, and then they did a polypectomy was performed. 47 is on surgery. The anesthesia by surgeon, reported general or regional anesthesia provided by the surgeon instead of the anesthesiologist. Example here, instead of a local anesthetic, a digital block was used. 50, it's going to be surgery and ambulatory surgery centers. That's your bilateral procedures. So you do not append this to CPT codes that identify bilateral procedures. Example is a right breast and a left breast procedure. 51 is multiple procedures. So it's anesthesia, surgery, radiology, and medicine. Multiple procedures and discounts apply. So you're not going to be paid 100%. So multiple procedures performed during the same session by the same provider, used for same operation, different site, multiple operations. You do not append to add-on codes. In the example, we would have 3 warts removed at different sites. 52 is for reduced services, evaluation and management, surgery, radiology, path, medicine, and ambulatory surgery. So example, cannot complete surgery as described, previously scheduled, procedure, service, partially reduced or canceled as a result of extenuating circumstances or threatened the well-being of the patient. So if there's a reason it can't be completed, we would put 52. And again, this is on CPT codes that do not have a lesser code to completely describe what was done. 53 is a discounted procedure, anesthesia, surgery, radiology, path, and medicine. So example, a patient developed an arrhythmia during surgery or blood pressure dropping. They had to stop the procedure. 54, surgical care only. The physician performs only the surgical procedure and another physician performs the pre-op and or the post-op. So an example here is the patient traveling through town has an emergent appendectomy. 55 is surgery and medicine. Post-op management, so that same patient that had the emergent appendectomy returns home and sees their doctor for the follow-up. Pre-op is 56, again is for surgery and medicine. Ophthalmologist asks the PCP if the patient is stable for surgery. 57, it goes on the evaluation and management. It's the decision of surgery. It's on the ones that are for 90-day global periods, the major surgeries. Office visit indicates a surgery immediately. Another example would be in the emergency department. The patient comes in because they have fractured their ankle or their hip and they're going to be repaired. Those are 90 days, so then we would apply the 57. 58 is staged or related procedure by the same provider during the post-op period. We have to complete the procedure in multiple stages. It's going to go on surgery, radiology, medicine, and ambulatory surgery. Grafts are done in stages. The biopsy, then the procedure was performed several days later. 59 is anesthesia, surgery, radiology, path, medicine, and ambulatory surgery. Distinct procedural service. Again, this is your NCCI edits. They're the ones that are going to state separate procedure. So you want to make sure that you review the edits to ensure that you can assign that. 62, surgery and radiology. There's 2 surgeons that are involved with the same amount of work. 63 is on surgery. Procedures performed on infants less than 4 kilograms. That is also 8.8 pounds. So there's typically a greater complexity to that. 66 is surgery and radiology. There's a surgical team. There's multiple specialists involved, such as an organ transplant. 76, we have surgery, radiology, medicine, and ambulatory surgery. This is going to be a repeat of the procedure by the same physician. So it has to be medically necessary to repeat it. Do not bill procedures that are performed to verify results or due to facility errors. So repeat EKGs, there has to be a reason for it. 77, repeat procedure by different physician, surgery, radiology, medicine, and ambulatory surgery. Repeat x-ray for more detail. That would be an example by another physician. 78, surgery, radiology, medicine, ambulatory surgery. Return to the OR for related procedure during post-op period. This is complications resulting from initial procedure. Second surgery was necessary to treat that complication, such as internal bleeding from the initial surgery. Say an artery was nicked and they had to go in and repair it. 79, surgery, radiology, medicine, ambulatory surgery. There's an unrelated procedure or service by the same provider during post-op. Example here, a patient recovering from hip surgery when they fall and fracture a wrist. 80, surgery and radiology. We've got an assistant surgeon, so provides assistance to the primary with the procedure. Bill the same procedure code and append the modifier as you would for the primary. 81 is surgery and ambulatory surgery center. Minimum assistant surgeon. This is assist for just a short period of time. And this is append 80 if the assistant is present during the entire procedure. So that's the difference. If they're there for a short period of time, it's 81. Entire procedure is 80. Example, an open spine and does not stay to complete the surgery. 82 is only for surgery. Assistant surgeon when qualified resident surgeon is not available. This has to be done in a teaching facility. So if your scenario says that at the teaching facility there was not a resident available to perform the surgery, this is when you would assign that. 90, surgery, radiology, path, and medicine. Reference to the outside laboratory. This is where you pull the labs, you do the cultures, and you send them off to an outside lab for them to read. Such as an urgent care clinic, physician collects the culture and sends it to an outside lab for the results. This is when we were talking about the CMS 1500 and you had to tell was there outside labs utilized. You would click yes. The ones that have a 90 attached, that would be the total charge. 91 is for path. That's going to be repeating the same laboratory test. So repeating the same panel, repeating the same test. Do not use it to rerun tests to confirm results, testing errors with specimen collection or equipment, or any other tests that require multiple samples, such as glucose tolerance. 92 is only on path and lab, alternative laboratory platform testing. So that's where you have a kit that you carry around, so you're not having to keep space in the laboratory or take the patient back to the lab to run tests. 95 is on the evaluation and management. This has to do with the telehealth. You're going to see that utilized more, but they do have to have the visit through a distant site, and they're going to be using a computer. Look at Appendix P for examples of when to use that. I didn't see an example of 95 other than maybe a potential question. If you do a telehealth visit, which modifier would you assign? And it gives you a list of different modifiers to select. That's really what the modifier questions are about. They give you a definition and you select the modifier based on which ones they give you to select from. 96 is medicine. Habitative service, most likely used for occupational and speech therapists. So it gives you an example there. Those are self-care training used when patient is taught how to groom himself due to intellectual disability. So they didn't already possess those skills. They're being taught new skills. Whereas 97, rehab, they had those skills before, but because they had a head trauma or a stroke, they're relearning them. And that's on medicine. 99 is multiple modifiers, and that's going to be used when you've utilized all 4 on the CMS 1500. Then you're also going to place information in that box 19 to further specify that you have more modifiers to use there. And then specifically just 2 ambulatory surgery centers is 27, which we assign to the evaluation and management and ambulatory surgery. Multiple outpatient hospital encounters on the same day. Another example here is you're seen in the ER and you go to observation, but you could also be seen in the emergency department first thing in the morning around 1 a.m. They discharge you at 4. For whatever reason, you're still not feeling well, so you come back again at 6 that evening. So you would assign the 27 on the second emergency department visit. 73 discontinued and 74 discontinued. So one is prior to administration of anesthesia and the other is after anesthesia has been provided. Both of those are done in surgery, radiology, path, and ambulatory surgery center. Finally, these are our Medicare modifiers. With our Medicare modifiers, we have XE, or separate encounter, XS, separate organ structure, XP, separate practitioner, XU, unusual non-overlapping services, normally what you consider 59. So any of these can be used instead of 59, because Medicare felt that 59 was overutilized, so they wanted specifics on when you would assign those. Use when no other appropriate modifier is available. Coding pairs of the NCCI procedure to procedure, they pretty much all say the same thing except what they're specifically used for. Separate encounter means they're going to be during a separate encounter. Distinct service performed on a separate organ. Distinct service performed by a different provider. And distinct service that does not overlap usual component. So again, everything that do not use. So same procedure performed twice on the same day. Do not use then. multiple drug administration of the same drug, and then with modifier 59. You couldn't use both of those together. But that concludes the introduction to CPT as well as just the overlook of modifiers. The rest of the test prep is broken down by either one section or several chapters within. Evaluation and management is by itself. There are questions that are specific to evaluation and management. I did go over a little bit more detail in the Blackboard handout. So that's something that you'll want to look at in addition to the evaluation management here, and when we look at the documentation area where you do the case studies.